Welcome to ATCM. Today we will be presenting a pediatric emergency case. Shall we start the class? Sir, a 4-year-old child has been brought with a alleged history of exacerbation of asthma. In my initial 10-second assessment, I immediately did my PAT triangle assessment. In that, in the breathing part, the work of breathing looks exaggerated. There was audible wheeze is there, and along with there is retraction of the nasal flaring and retraction of chest was there. Use of external intercostal muscles were also visible, sir. And otherwise, child looks less intractable. Child was almost lying along with the mother's body, and otherwise not having any cry or abnormal speech. Nothing was noted.
Was the child drowsy?
Not because of the respiratory distress. He is having an E4 movement, but lying over the mother, but not crying, not looking irritated and all, but looking a little lethargic.
Lethargic child. Is that a good sign in asthma?
It's actually not a good sign, sir.
What does it? What can you clinically suspect if you see a lethargic child with
one thing is that if associated with severe associated hypoxia may be a possibility. Hypercarbia is a hypercarbia is a possibility.
Hypercarbia. In that part you should always be keeping in mind. The hypercarbia patients can become suddenly lethargic and drowsy.
Carbon dioxide narcosis.
Pardon.
Carbon dioxide narcosis.
So otherwise no pallor or mottling was not there, sir. So immediately I started my primary survey.
Patients had any cyanosis?
No cyanosis.
CRT was good?
CRT was good, sir.
Those are important.
Yes, sir.
Patient is having acute breathing difficulty. It can be an infective cause causing acute breathing difficulty. Even though it is asthma, it can be infective exacerbation also.
Yes.
So we need to look for infective causes also, which can affect cardiac status.
Child is talking or making any noise, moaning or anything, or just
child was not talking, sir, not crying, not irritated, but we can hear the audible wheeze was there. So immediately we started our primary survey. Airway is patent. When I asked to open the mouth, the child was able to open the mouth and protrude the tongue out, and the cervical no movement restriction, it was normal. So immediately I assessed to the breathing part also. Air entry bilaterally equal, but bilateral air entry is there, but severe expiratory wheeze was even without this test audible, sir. So at that time, saturation maintaining around 96% in room air. Respiratory rate it was around 36. For his ideally it should be between 20 to 30, but it is around 36 breaths per minute, sir. But no associated CRUBs was not there. So at this point in time, we intervened. We started the child on a salbutamol nebulization was there. We prefer levosalbutamol. In that, we give around 2.5 ml, giving 2.5 mg levosalbutamol mixed with the normal saline. We started the nebulization. There, sir. Then I went to the immediately circulation part.
How do you know this patient is having wheeze and not stridor?
One is stridor, the quality of the sound is itself a difference, sir. Wheeze is a more of a musical note. Stridor is more of a harsh voice, sir. And usually stridor it can be inspiratory or expiratory, or both inspiratory and expiratory, depending upon where the position of the location. And again, if it is a stridor, the most common etiology is comes under it may be epiglottitis or a croup or a tracheobronchitis. And scenarios
these are very common in
pediatric child group. At that time, associated other clinical symptoms will be also be there. For example, croup means the child will be not so sick looking, but there will be gradual onset history will be there. Barking, cough will be, everything will be audible, sir. Tracheobronchitis, severe amount of secretion, cough will be there. If it is associated epiglottitis, means there will be pooling of secretions, and the child won't degluticate because of, deglutition will be impaired because of severe pain. So such kind of clinical features were not there. Beyond that, I will come in the secondary survey. We got the history that child has an episodes of asthma in the past, but on taking levosalbutamol syrup alone. Similar episodes in the last year, everything was there, sir, and the history of asthma history there in the mother also. So I am expecting more to be an asthma exacerbation. So then I went to my circulation part. In circulation, the NIBP reading was around 100/60, sir, which is also within the normal range for that, adequate for that age. Otherwise, the pulse rate was also around 96 per minute, maybe because of the associated respiratory distress. But otherwise, CRT was less than 2 seconds, no other external injuries or no cyanosis, sir. And GCS was E4, V5, M6, full GCS was there for the child, and pupils were 2.5 mm bilaterally reactive, and we didn't go for the GRBs at that time because we don't want to irritate the child. Then otherwise peripheries were warm, and child is along with the mother's care. So as an adjunct, I didn't want to intervene with any ABG or X-ray at this point of time, because I'm expecting this to be an asthma exacerbation. In that scenario, it is not usually indicated. But in case of expected, at this time my provisional diagnosis will be, it is a case of probable moderate to severe asthma, sir. No features of life-threatening asthma is not there. No features of cyanosis or confusion or any hypotension or arrhythmias or such features are not there. And so I'm having a saturation more than 92 also, probably it will be moderate asthma, and expecting to have a better response to the bronchodilators.
Temperature?
Temperature was also normal, sir. No episodes of fever. The child came with around 4 o'clock morning, so with early, maybe because of cold, a child might have got an exacerbation, sir. So I didn't intervene, asked for any adjuncts at that time. Then I proceeded with my secondary survey. In secondary survey, I asked for the history of allergies. As such, they have not noted any specific allergy to any food materials or drugs or something. But in past history, multiple episodes of, even in child less than 1 year itself, there are episodes of asthma, wheeze was documented. And last episode was around previous year, which was around 6 to 7 months back. And in that time, every time with no requirement for a hospital admission, with the conservative management in the ED itself, child was improving and got discharged at all the time. And but not on any chronic nebulizers or syrup something. Intermittently, child develops episodes of cough or something. Their mother used to give salbutamol syrup. That's the past history of medications and past relevant history. Even now, that led to the arrival is that child was asymptomatic yesterday night, playful, but they were sleeping, and by morning child they were noted to have multiple episodes of dry coughs. Along with the child was not sleeping, and child was leaning forward in sitting position because of severe breathlessness, following which mother has brought the child to us. That's the event lead to us. Then otherwise, head to foot examination, it is adequately grown for gestational, grown for the age baby, adequate milestones according to the age. Otherwise, no gross abnormalities were detectable, sir. It was a male child. Otherwise, head and spine, no obvious abnormalities were detected, but chest retractions and flare, the prominence of sternocleidoid muscles and the nasal flaring was noted. And but subsequent around 45 minutes, actually child becomes symptomatically little bit better. And otherwise, there was no obvious abnormalities. Chest bilateral wheeze was still persisting, even though patient symptomatically improved. Wheeze was still persisting, but air entry bilaterally equal. No obvious crepitations or any other possible OCT findings were present. And abdomen was a per-abdomen, soft and non-tender. Patient child has passed stools today morning. No other issues were there, sir. Then coming to gross external examination, there was no rashes or no other cutaneous edema or erythema or no other external features were also present, sir.
Any family history, any seasonal
mother
variation?
Mother is
seasonal variation.
Mother had a childhood history of asthma.
Okay,
Currently,
okay.
she's fine.
And after nebulization, whether there was increase in the saturation?
Then after around, actually we gave salbutamol nebulization. Along with the second cycle of we gave ipratropium bromide also, 500 microgram nebulization was also given. But so we gave around 3 cycles back to back for 20 minutes, and we reassessed the child by 45 minutes, around 45 minutes. At that time audible wheeze was still there, but child was symptomatically better. And her respiratory rate also started to around 32, it came down, and the work of breathing on the external appearance looked better. So anyway, we actually continued for another set of ipratropium bromide along with salbutamol nebulizations were again given after 45 minutes again, because it was audible wheeze was still there in while auscultation. So at this point I came to the provisional diagnosis that it is a possible case of acute asthma exacerbation, and possibly a mild to moderate asthma exacerbation, but responding to our medications. So along with that, so after around another 3 more cycles of total 3 cycles of nebulizations, child was the wheeze disappeared, sir. Child became symptomatically better. So we planned for discharge, and we explained to the mother any kind of life-threatening issues which is associated with asthma. In such a scenario, the mother has to bring to us immediately, and we told them in case of any cyanosis or severe respiratory rate worsening, or in case if they are associated severe tachycardia or any cyanosis, or a child become silent chest, or any worsening drowsiness or sensorium, immediately to bring the child back. But mother is already an experienced person. Because she knows the symptoms, she is already has similar episodes in the childhood. And we gave her with, again continued, asked them to continue with the salbutamol syrup. Along with that, we started him a dose of steroid also started. Dexamethasone 0.15 mg per kg oral steroids were started, and asked them to continue for 5 days and to review with our respiratory therapy or our pediatric departments for follow-up, and to advise regarding disease time modifications and how to avoid the asthmas and all, and also to calculate our, if the child is cooperative, our peak expiratory flow rate for the baseline, sir. So this is the normal scenario. If the same child was not responding irrespective of our treatment, then we should always have the alternate treatment options in case that is we are expecting a refractory asthma.
So you are going to treat all asthmatic patients in the same level, or are you going to classify the asthma patients according to the symptomatology?
Yes, sir. Again, we can classify the entire asthma into either, just like mentioned, mild, moderate, severe, or the life-threatening asthma. If it is in the case of UHA guideline, near fatal, there is another classification along with the moderate, severe, and life-threatening. Near fatal asthma is also there. So in moderate is that if the child is able to, and these are the classification even before we initiate a treatment. If at the present time of presentation itself the child is able to speak, and if the child is maintaining a saturation more than 92%, or if the pulse rate is less than 140 for a child less than 5 years, in such a scenario we can consider it as only a moderate asthma. In severe asthma, the child is unable to speak, and the child is not able to maintain a saturation less than 92%, or if the heart rate is more than 140, respiratory rate more than 40. In such a scenario, we have to treat it as severe asthma. In life-threatening asthma means saturation again less than 92%, but other complications like the patient will have hypoxia, patient will have confusion, arrhythmias, hypotension, such kind of features will also be there, cyanosis. This can all be life-threatening. Whenever there is associated type 2 failure, that is associated increase in PCO2, or the patient irrespective finally landed up in a mechanical ventilation, then we have to take it as near fatal type of asthma. Here in such a scenarios like life-threatening or near fatal asthma, always our initial management is with the use of short-acting beta-2 agonists like salbutamol. Better is a levosalbutamol, along with the anticholinergic ipratropium bromide. Along with that, we always initiate steroids for all kind of asthma, just like dexamethasone intravenously, or an oral preparation can be started. But irrespective of our treatment, and one more option is that if the child is already using a metered dose inhalers, usually it has 100 microgram preparations. we can give around 5 to 8 puffs of meters dose inhaler. Puff can be taken simultaneously back to back, and we can reassess every 20 minutes. Along with, if it is better, if it is coming with a spacer, so the compliance will be little bit better. And if it is not, the child is not relieving with short acting beta 2 agonist and anticholinergics along with steroids, then our next option is that we can go for terbutaline subcutaneous injections is an option. And then another option is that then we have to give magnesium. 50 milligram per kilogram magnesium loading can be given, sir.
What's the role of magnesium in asthma?
Again, bronchodilation, it has property.
Very smooth muscle.
Smooth muscle relaxation of bronchodilators. Another upcoming is that use of adrenaline subcutaneously. It is also proven to be effective, sir, equivalent to effectivity of terbutaline and salbutamol.
What is the important feature that you will look at before giving adrenaline?
Adrenaline, one thing is that associated cardiovascular, heart tachycardia, such kind of parameters can be also be looked at.
Patient with severe respiratory distress will be having severe tachycardia.
Tachycardia, sir.
So that part we have to be making sure before we think about adrenaline as a drug
of choice. And
And
finally,
what is the steroid you will prefer, and what is the mode of administration?
steroid, both hydrocortisone or dexona can be used, sir. But predominant anti-inflammatory action will be little bit for hydrocortisone compared to dexona, sir. It is entirely actually because of the mucosal edema that's causing the broncho obstruction. So we can give both hydrocortisone, but only mild difference in the efficacy. Both the hydrocortisone or dexona can be used. Again, both intravenously or perorally can be given, sir. But in case of severe or life-threatening as a oral complaints will be bad. In such scenarios, we can go with the intravenous administration of steroids. And at the last resort is that even with our refractory asthma not responding to our initial drugs, if the patient is even irrespective of our treatment, child is not improving or the associated type 2 failure is developing, then we have to go ahead with the invasive ventilation has to be taken care, where we will be using the preferred drug will be a ketamine, and we can muscle relaxant other than atracurium or cisatracurium, other drugs can be used. And ketamine has the additional bronchodilatory property, 1 mg per kg we can be used here, and we can go ahead with the controlled mechanical ventilation to prevent hypoxia and hypercarbia. That's the final resort, sir.
Ketamine usual dose for intubation is?
Ketamine usually is 1 to 1.5 we can use, sir. mg per kg we can use.
What are the contraindications for ketamine?
Ketamine, whenever there is associated raised intraocular pressure or intracranial pressure associated severe coronary artery disease, such scenarios we have to be careful with using ketamine.
Is there a current contraindication against raised?
No, currently raised intracranial pressure, ketamine can be used even in trauma patients.
Contraindication is basically intraocular
Ocular pressure, IOP is
intraocular pressures. Patients having aortic dilation, root of aorta dilation. Previous cardiac history, and coronary artery disease patients with critical stenosis. Those things we can take care of. Now, if this patient is presenting to ER having breathing difficulty, you have started your nebulizations, but a child is having not much of improvement, and his hypoxia and respiratory distress is worsening. What will be your next step? This patient came to you, you started nebulizations. With the nebulizations, child hypoxia is not improving, child's hypoxia is worsening, he is desaturated down to 88% with 8 liters oxygen, and this is also not improving. What are the other options of ventilation that you can provide to the child?
One is HFNC or BiPAP can be tried, sir, but make sure that child has the adequate respiratory drive and sensorium is preserved. In such scenario, we can go ahead with trial with the NIV, and if associated only hypoxia is there, HFNC can also be tried, sir.
NIV you are planning, what is the best modality, mask that you can use for a child? Do you use the same nasal-oral mask or nasal mask or face mask or herbal mask?
In pediatric, it is better the nasal bubble CPAP is the good opportunity. That is associated warmer and the humidifier, everything will come along with that. The nasal CPAP is
Nasal
CPAP.
Where is, sorry, carry on. Carry on. Where does the salbutamol or ipratropium act?
Sir,
What
these
is
are
the
all
mode of action?
beta-2 agonist, local action over the beta-2 receptors that are present over the smooth muscles, sir. Direct action.
But more action is, salbutamol has a more action on?
Beta-1 and beta-2 both it has, and associated beta-1 cause tachycardia. Everything
Continuous
can cause.
ECG monitoring also.
Yes.
Correct, And one school of the recent studies is, see, this is the three components in the bronchial asthma. One is mucosal edema and increased secretions and bronchoconstriction. These drugs act at the level of the bronchi to dilate it. So already there is an edema, this drug may not be reaching even if you are giving it. So anti-edema measures first preceded before inhalation. The steroids, then it will immediately release the edema measures so that the other drug following inhalation drugs will be reaching the terminal receptors also. The action will be better than this one instead of first trying this one in severe cases.
Okay.
So, what is the importance of bedside flowmetry testing for acute asthmatic patients?
One is that we can immediately grade whether comparing to the, how much percentage the peak expiratory flow rate has come down, sir. Ideally it should be more than 75%. It is between 50 to 70 means it comes under moderate. If it is between 33 to 50 means it becomes severe. If it is less than 33% means life threatening. But again we should have a baseline flow rate of the patient.
But that is to identify how much
One
worse the patient is.
next is response to the bronchodilators. If there is with just beta-2 agonist, if there is an associated increase of 12 to 15% in peak expiratory flow rate, then it's a responder asthma, kind of asthma.
If the patient is compliant enough, if the flowmetry can be done bedside, we can identify whether our treatment is successful or not to the patient, and whether the patient will be able to be discharged or should you admit the patient for the management. So the initial presentation of mild, moderate, severe and life-threatening asthma along with the flowmetry can really guide you to make a decision which patient to be discharged and which patient to be admitted. Now, if this patient is not improving with your traditional methods of bronchodilators or steroids, will you start aminophylline for this patient? Aminophylline is a common treatment modality that was used earlier with IV infusion over 24 hours. So, this patient is not improving. How will you proceed?
Aminophylline infusion is currently because of its arrhythmogenic property, it's not recommended. But in case of last resort, it's not absolutely a contraindication also. In case of last resort, we can, in a non-responders, we can try for an aminophylline infusion with the proper cardiac monitoring, rhythm monitoring.
There is a very high chance of cardiac arrhythmia, so severe tachycardias to be happening. So continuous monitoring is needed. But it has now taken out from almost all
guidelines. It's not recommended.
Treatment modality, because they are saying even if with aminophylline, the risk versus benefit is very low. And if the patient is having severe bronchospasm, which is not improving with the medications and beta agents, intubate the patient and continue the same management. Now, if this patient is ventilated, what is the important ventilator parameters that you will set for this patient?
One important difference compared to other, just like all the obstructive airway diseases, the possibility of dynamic hyperinflation is one issue, sir. Because of the severe bronchospasm, at the end of expiration, the entire air may not have come out. So there will be continuous build-up of autopsy, and as a result, there can be hemodynamic compromise, along with the further decrease in lung complaints and further worsening of hypoxia can be a possibility.
How will you see that in a patient? So you have intubated this patient. After intubation, initially patient's tidal volume was let's say 200. It's a pediatric child. Let's say it was 200. Patient's air entry was improving. After some time, some abnormality happened. You are suspecting dynamic hyperinflation. What are the ventilator changes or hemodynamic changes you will see which will make you doubt it's
Dynamic hyperinflation. One is associated hypotension if the patient develops. Then another important thing is that ventilator loop, the pressure volume loop, it won't be touching the baseline at the end of expiration. There will be some amount of residual volume still persisting. That also suggests that the patient is not completely expiring, sir. These are the two
So basically there will be loss of tidal volume. There will be loss of tidal volume, and there will be a pressure volume loop not getting completed. The compliance of the lungs will be decreased. And in severe cases, it can even affect hypertension. That hypertension is due to
decreased venous return, due to increased intrathoracic pressure. And then in some ventilators, it can calculate the auto PEEP and it can show how much it is building up.
Any measures to prevent or treat auto PEEP?
Prevent is that to first to increase the expiratory time and to decrease the respiratory rate, only to maintain just an adequate respiration to prevent hypoxia. And treatment is that once it develops, just to disconnect the ventilator for around 30 seconds so that the built up O2 can be completely expelled out, then again start the ventilation with the newer ventilator modalities.
So decreased tidal volume, adequate tidal volume, not decreased tidal volume, adequate tidal volume management with the intermittent release of positive pressure ventilation.
Yes.
See, 2-3 things, important things. No? The children are more prone for hypoxia.
Yes, sir.
So suddenly going for cardiac arrest. So this you have to keep in mind. And earlier we have to go for the remedial measures. Number 2, regarding the workup breathing. The children cannot be able to tolerate for a longer period workup breathing. They reserve the muscles all will be not well developed. So they will become soon fatigued.
Yes, sir.
And immediately these people will go for respiratory arrest, impending respiratory. Within short time, we can't predict and wait. So in such cases, we have to be very alert, and the earlier institution of the controlled ventilation is better. Third, even though when you are putting a tube on auscultation, it may wrongly, there will not be any breath sounds heard, silent chest like that. So we should not immediately take the tube out or go for the conclusion that we are not. Okay. When you are visualizing, make sure that you are passing into the glottic opening. Number 2, ET-CO2 is an ideal thing, more than relying on the auscultatory findings.
Any indication for antibiotics?
As such, for treatment of isolated asthma, there is no indication for antibiotics.
Okay, that's it, right?
Okay.
Good presentation.
Thank
Good.
you. Thank you.